What's up, Ninja Nerds? In this video today, we're going to be talking about coagulopathy. Again, this is a part of our clinical medicine section. If you guys like these videos, they make sense to you, please support us. You can do that by hitting the like button, commenting down in the comment section, or subscribing. Also, do yourself, I really think, a courtesy and go down the description box below, click on the link that goes to our website. On our website, if you become a member, you'll have access to thousands of notes, illustrations, tons of quiz questions, and there's even some board exam prep courses that are being made as well. So go check that out. Without further ado, let's really dig into coagulopathy. All right, so let's start talking about the pathophysiology of coagulopathy. So when we talk about coagulopathy, the biggest thing to remember here is that they'll present with bleeding, right? So it's an abnormality within the coagulation cascade. And bleeding can present a couple different ways, right? One is they can present with like superficial bleeding. Superficial bleeding is more characteristic of platelet disorders, right? So a thrombocytopenia or a qualitative platelet dysfunction kind of disorder. And so when you think about superficial bleeding, you think about petechiae, you think about gingival bleeding, you think about maybe prolonged vaginal bleeding or heavy menstrual bleeding, like in menorrhagia. You think about bleeding kind of a little bit longer than normal after like a minor cut. When you think coagulopathy, you think big bruising or hematomas. So you think about ecchymosis of the skin. You think about hemarthrosis, so a lot of bleeding into the joints. You can think about deeper bleeding, like intracranial bleeds, GI bleeds, and prolonged bleeding after surgical procedures. So that's suggesting a coagulopathy. Platelet disorders, again, it's either due to it they're too low or they're not working. When we talk about coagulopathy, there is usually, almost most of the time, a deficiency in a particular clotting factor that's involved in the clotting cascade, or there's something that's inhibiting that clotting factor from being able to function in the coagulation cascade, all right? We can break that down into three different ways. One is a defect of only the intrinsic pathway. One, a defect of only the extrinsic pathway. Or the last one, a defect involving both pathways, meaning that this one involves a ton of different coagulation factors. So let's kind of quickly, and I'm not going to go through the entire cascade in detail. I want this to be more of a recap. And if you guys remember from basic physiology that you have what's called factor 12. Now factor 12, clotting factor made by the liver, moves through the bloodstream, sees a negatively charged surface on the platelet and does what? Binds to it and gets activated. When it becomes activated, it then activates a couple other factors that are in the bloodstream. The next one is factor 11. Factor 11 then activates factor 9. Factor 9 then combines with factor 8. And when they combine, they activate factor 10. Factor 10 combines with factor 5 and activates factor 2. You know what another name for factor 2 is? We like to call this thrombin. And then thrombin converts factor 1 into 1A. You know what we call 1A? Fibrin. So fibrin. And this one here, 1, is fibrinogen. We'll bring this one over here a little bit more so we have more room to write that big frickin' name, but this is fibrinogen. So what happens is once you have the platelet that comes here, sees an injury of the blood vessel, the platelet should come and stick to this area. Where's my marker here? Here it is. This guy is gonna come stick to this injury of the blood vessel wall. And the reason why is there's this blue subendothelial collagen that the actual platelets love. And then the endothelial cells release von Willebrand factor and the platelets will stick. And they'll start aggregating and releasing more cytokines to cause more platelets to come to the area. Once that happens, factor 12 should bounce off of that, go through this whole pathway, and eventually lead to what? The formation of fibrin. What's fibrin supposed to do? Fibrin is supposed to come over here and lay down these strands that basically anchor the platelet plug down. So this triggers primary hemostasis, the platelet plugs, and then the coagulation factor, which leads to fibrin, leads to the secondary hemostatic plug. If a patient has some type of deficiency, or maybe not just deficiency, but something that is inhibiting that clotting factor. So some type of factor inhibitor of any of these clotting proteins that I mentioned here. These, primarily, it does also affect the common pathway, but we're talking about primarily these proteins. If there is some type of, two different things here. One is there a deficiency of any of these clotting proteins that are boxed in red? So deficiency in clotting proteins? Or is there a inhibition? All right, is there an inhibitor of these clotting proteins that are boxed in red? Because if there is one of these two things, a deficiency or an inhibitor, then what's going to happen? If I have less factor VIII or less factor IX, I won't be able to activate factor X. I won't be able to activate thrombin. I won't be able to convert fibrinogen into fibrin. If I can't form fibrin, can I make the fibrin mesh? No. If I can't make the fibrin mesh, this leads to inability, so this leads to an inhibition or a decreased secondary hemostasis. And that's going to lead to bleeding. Now, when we have patients who bleed, again, the difference in the coagulopathic patient is that it's more of that deeper bleeding. But that's not always a perfect thing. So one thing that we like to do is we like to get some labs. And it's actually kind of cool. So you take the patient's blood, all right? So here's the patient's blood. And what I'm going to do is I'm going to take this blood and I'm going to add in some type of like activator. Usually it's like silica. So that's a common one. But we'll add in this like thing like silica. And maybe we'll add in some other things, but you're trying to add something that has a negatively charged kind of property to it. When you add that into the mix, that negatively charged surface on the silica basically activates factor 12. And if you activate factor 12 and you give it like calcium and things like that, guess what it's going to do? It's going to trigger the coagulation cascade, the intrinsic pathway, and it'll lead to clotting. But if a patient has an intrinsic defect, so now you exhibit an intrinsic defect, what the heck does that mean, Zach? Come on, man. It's a defect in factors 12, 11, 9, or 8. They don't lead to, if you don't have those factors, it doesn't matter. You're not going to be able to lead to this clotting cascade occurring. And so because of that, the intrinsic pathway will be hampered. It'll be impaired. So if you have, let's say, a deficiency in factor 12 or a deficiency in factor 8, you can go through this process, but you'll never lead to fibrin formation effectively to lead to a clot. That means the time it takes to clot is going to be prolonged. So this leads to a prolonged clotting time. But it's a prolonged clotting time that is what we refer to as the partial thromboplastin time. And so really this increased clotting time is particularly referred to, and we'll write it here, as the PTT. It is prolonged. So whenever you see a patient who has an increased PTT, you think intrinsic defect, deficiency in which ones? 12, 11, 9, 8. That's it. It's an impairment in secondary hemostasis. That's why they're bleeding. I just have to figure out why. And guess what? It's pretty easy, and we'll talk about it later. If it's 9, it could be hemophilia B. If it's 8, it could be hemophilia A or von Willebrand's disease. And another thing is that sometimes it could actually be due to a factor inhibitor, an antibody that binds against factor VIII and renders it useless. And sometimes it could be due to an anticoagulant that inhibits thrombin. And you know what thrombin does? Thrombin activates factor VIII. And if I don't have thrombin, can I activate factor VIII? And can I activate factor IX? No. So that's why it's important. So that's the intrinsic defect. What about extrinsic defect? So extrinsic defect is there's some type of tissue injury, and that tissue injury leads to the release of what's called tissue factor. Now, tissue factor is also referred to as factor 3. Now, once it gets released by the tissues, or once it's actually moving through the circulation, it's in its inactive form. When there's tissue injury, that cytokines will then activate tissue factor, turn it into its active form, right? So we're going to represent this as 3A. It's activated. 3A is going to combine with another factor here, which is called factor 7. And factor 7, when activated and combines with factor 3, guess what it activates? Factor 10. Factor 10 combines with factor 5 and activates thrombin. And then thrombin converts factor 1 into 1A, which is essentially converting fibrinogen into fibrin. Man, we good. And by doing that, you're supposed to lead to fibrin formation, because what happens is there's tissue damage. When there's tissue damage, you may injure the endothelium. When you injure the endothelium, it causes the platelets to stick. because they see the subendothelial lining. When that happens, the platelets start forming a primary hemostatic plug via the activation, adhesion, and aggregation. Then that fibrin is supposed to come over here and help to make what? That fibrin mesh, which helps to stabilize it and form secondary hemostasis. If a patient has a deficiency, and I'd say the primary one here is factor 7. A deficiency in factor 7 will lead to a decrease in factor 10 formation, a decrease in thrombin, and a decrease in fibrin formation. And if you can't form fibrin, can you form a secondary hemostatic plug? Nope. If you can't form this plug, can you stop yourself from bleeding? No. And if you can't stop yourself from bleeding, this is what we would refer to as an abnormality in the coagulation cascade, referred to as bleeding. All right? Or coagulopathy, I'm sorry. Now, real quick, intrinsic defects could be due to inhibitors or deficiencies. Extrinsic defects are primarily due to deficiencies. All right, so that's kind of quite important to remember that this one is usually due to a deficiency in factor 7. That is important to remember, okay? Now, here's what's really cool. Factor 7 is the big one that we need to know for the extrinsic pathway. Whenever there's an impairment in factor 7, we can measure that, because factor 7 needs tissue factor. So what I'm going to do is I'm going to take the patient's blood and I'm going to add in tissue factor. We don't call it tissue factor, we call it thromboplastin. And what this is going to do is it's going to act like tissue factor. When I add that in, what it's going to do is it's going to help to activate factor 7. And factor 7 should then activate eventually factor 10, lead to fibrin and form a clot. But if a patient has a factor 7 deficiency, would it work? No. So in the presence of an extrinsic defect, it won't matter if you add the thromboplastin, because you don't have enough factor 7 to become activated and lead to active factor 10. And so because of that, what happens to the time it takes to clot? It becomes prolonged. And that increased clotting time in this scenario is measured via a different type of study. And this coagulation study is called the PT. And sometimes what we like to do is, this is measured in seconds, but we can take the PT of the patient and then compare it to the PT of the standard PT in that given area, institution, hospital, whatever, the laboratory. And then you take the PT of the patient over the PT of that standard, and you get what's called an INR, an international normalized ratio. And so these are somewhat, they're not synonymous in the sense of the units, but they kind of give about the same concept, that they both measure the activity of the extrinsic pathway. And so in this particular scenario, it'll be prolonged. So if I said PTT is prolonged, you would say, okay, that's a problem with factor 12, 11, 9, 8. If I said PT-INR is prolonged, you say that's primarily factor 7. If I said, okay, it's an intrinsic defect, is it a deficiency or an inhibitor? It could be both. If I said it's a problem with an extrinsic pathway, you'd say it's primarily deficiency. Which factor? Factor 7. All right, so now we're going to talk about the last one, which is a combination of both of these pathways. So there's some type of deficiency that's really existing between both of these pathways. And let's quickly remind ourselves, again, what are these pathways again? Let's start with the intrinsic and the extrinsic and see how they come together in the common pathway, and then talk about which ones are most commonly affected. So again, we'll start with the intrinsic first. So now, with this being said, we've gone through the combination of these pathways and see how we lead to the formation of fibrin. In a patient who has an extrinsic and intrinsic defect, there's a deficiency, usually, of any of these factors here, as well as a deficiency in this. And so, again, you can see how an intrinsic and extrinsic defect, and also just extrinsic defect, what do you usually have to have? In this case, you need a deficiency of the following clotting factors. With that being said, if I have a deficiency of these, I'm going to lead to the same concept here. Less factor 10, less thrombin, less fibrin. So if you have an endothelial injury or you have something that causes damage to the endothelial lining, guess what happens? You'll trigger a platelet cascade, a platelet plug to form. And so I'll get my primary hemostasis via the platelets coming here and sticking. And then what should happen? Fibrin should come in, as we've talked about 2 times already, and lead to the formation of the fibrin mesh. But again, because there is some type of abnormality here, or deficiency, I should say, of these clotting factors, it leads to less fibrin, and you won't be able to lead to this fibrin mesh. As a result, there's a decrease in secondary hemostasis. All right? If there's a decrease in secondary hemostasis, I bet you can guess what's going to happen, my friends. It's going to lead to bleeding. We have a patient with a deficiency in a bunch of different clotting proteins here. That's pretty terrifying. Sometimes it can even involve some of these other clotting proteins in the common pathway. Now, with that being said, since it's technically involving coagulation factors in the intrinsic pathway and coagulation factors in the extrinsic pathway, wouldn't we then, if we took a patient's plasma, added silica to it, what would happen to their PTT? Well, these are affected. Would you be able to activate factor 12? Well, if not, if it's deficient, even if you had factor 12, would you be able to lead to this whole pathway down to factor 10? If you were missing or having an inhibitor of one of these? No. So what's going to happen to the patient's PTT in this scenario? It's going to be prolonged. So they'll have a prolonged PTT. And if they have a deficiency in factor 7, if you add thromboplastin, but they have a deficiency, is it going to matter? No, because again, you don't have the 7 to be activated because thromboplastin is just tissue factor. So what's going to happen to their PT-INR? It's going to be prolonged. So when a patient has a prolonged PTT by itself, you say 12, 11, 9, 8. When you say prolonged PT-INR by itself, you say 7 deficiency. And if I say an increased PTT and an increased PT-INR, you're saying there's a deficiency of maybe any of the coagulation factors in the intrinsic pathway and factor 7 in the extrinsic pathway. Now that we've done this, what do we need to build upon? We need to build upon what are the diseases or the causes of these deficiencies or inhibitors, deficiencies or deficiencies. Let's do that now. All right, my friends, so now we're going to talk about the causes of defects in the intrinsic pathway. So there's something wrong with 12, 11, 9, and 8. So when we talk about these, I want you to remember that there's 2 types that are inherited, and this is hemophilia A, hemophilia B, and then on top of that, we'll technically include in this last one, severe von Willebrand's disease. Now, whenever I have a patient who has a prolonged PTT, my differential for inherited causes should be thinking about, all right, which one is it again? Hemophilia A, B, von Willebrand's disease. What should I look for in the clinical vignette to suggest this? I want to see a patient who has a family history of some sort of severe bleeding or of these disease. So really examine the vignette for a family history of bleeding or some type of bleeding disorder, mainly hemophilia A, B, or von Willebrand's disease. Now, with that being said, when a patient has some type of bleeding like this, hemophilia can actually come in 2 different flavors, right? So one is you're going to have hemophilia A, and the other is going to be hemophilia B. Hemophilia A is going to be extremely much more common. Now, hemophilia A is a deficiency in factor 8. All right, so that's what I want you to remember. There is a decrease in which factor? Factor 8. And again, that's a factor that's involved in the intrinsic pathway. All right? So if you have less of him, you can't combine with 9 to activate 10. Boom. The other one, which is less common, is hemophilia B. Now, hemophilia B is usually a deficiency in factor 9. So you have a decrease in factor 9. And again, factor 9 does what? That puppy is supposed to combine with factor 8 to activate factor 10. So if you have a deficiency of him, can you activate factor 10? Can you lead to thrombin and fibrin? No. So the big thing for these is that these usually, again, you're looking for a family history of bleeding in both of these. But here's another thing. Hemophilia is X-linked. And so that's another really important thing to remember is that these, and I'll put this up above it, these are X-linked. meaning that you really will only primarily see this in males. All right, so X-linked recessive disorder. So that's why you really want to look for this in a patient who has a family history of hemophilia. They're most likely going to have that as well. All right, if I have a deficiency in these, we can see why both of these would lead to a decrease in thrombin, a decrease in fibrin, and I won't be able to do what? Well, I'll be able to form my primary hemostatic plug, but will I be able to get that fibrin, which is the 1A? Will I be able to bring this one in here to lead to that fibrin mesh? No. So this one will be okay, but this one will be inhibited. Big thing here, von Willebrand's disease. This one actually comes in 3 different flavors. So there's type 1, type 2, and type 3. Type 1 is the most common, type 2 is the next most common, and type 3 is extremely rare, but unfortunately it's what we're talking about here in the coagulopathy lecture. So type 1 von Willebrand's disease is when you have a very, very low level of von Willebrand factor. And you know what von Willebrand factor is supposed to do? It's actually kind of cool. So von Willebrand factor will actually bind with factor 8. So here's factor 8, right? And what will happen is these two will bind together. So we'll kind of represent it like this. Imagine here's von Willebrand factor and the blue. And then here in this black dot, or this black triangle, we'll say, is factor 8. All right, so this is von Willebrand factor. And then this guy right here is factor 8. Right there and there. What this does is there's a protein here, and we'll represent this one. Let's do it with pink. There's another enzyme here, or kind of a clotting factor per se. And this one is called protein C. So this one's called protein C. And protein C is actually designed, it wants to degrade factor 8, so it wants to degrade it. But because von Willebrand's factor is bound to it, it protects it, and basically it prevents its degradation. So this will do what? It'll prevent factor 8 degradation. And that's what basically saves factor 8 and keeps the factor 8 levels normal. So if a patient has a deficiency in von Willebrand factor, will it be able to bind factor 8 and keep factor 8 safe from protein C? No. And so what will happen to the factor 8 levels? They will drop as well. And so a patient can develop a deficiency in both the von Willebrand factor and factor 8. In type 2, which is the next one, it's the second most common. This one is where your von Willebrand factor and factor 8 levels are completely normal. It's just they don't work properly. So this is a dysfunctional von Willebrand factor. It just doesn't work properly. So it doesn't connect with the GP1B on the platelets to lead to a good platelet plug. And the last one here is type 3. And type 3 is the most severe, but it's also the most rare, probably less than 1% of patients who can get this. But if it happens, this leads to no von Willebrand factor, almost zilch, nada, as well as almost no, as a result, factor 8. Protein C will degrade the son of a gun out of that thing. So what are you left with? You're left with almost no von Willebrand factor and almost no factor 8. So now, if I have less factor 8, or worst case scenario, no factor 8, or best case scenario, I have a little bit of less factor 8 than normal, this can potentially act like a coagulopathy because these are a part of the intrinsic pathway. So these patients can have this terminology of a coagulopathy. But oftentimes, more than not, von Willebrand's disease will present as a platelet disorder. So it'll present with epistaxis, mucosal bleeding, menorrhagia, right? Petechiae. Not too often will present with this coagulopathic type of presentation. In rare instances, it may, if it's severe and you have no von Willebrand factor, to bind to factor 8 and protect it from protein C degrading it. All right, so if I have to determine between these two, how do I really determine the difference? Well, von Willebrand's disease versus hemophilia A, they both have maybe in some degree a deficiency in factor 8. But really, it's the von Willebrand factor that it would be low here, normal here. That's the big difference. All right? All right, we talked about these. Let's now talk about the acquired cases. So in acquired cases, this is going to be, I think, probably the easiest one. If you see a patient who has a prolonged PTT, they don't really have any significant family history of bleeding that is present, I would definitely be looking through their history for an anticoagulant like heparin. So if there is heparin use in their history, this is definitely something that you want to consider, especially if there was maybe too much, like an overdose. So if a patient's on heparin, and let's say that they just get a little bit too much heparin, more than they should have, right? Because heparin's supposed to act as an anticoagulant. Well, how does it do that? Well, basically what it does is it acts on this protein here. And this is an anticoagulant protein called antithrombin 3. Now, antithrombin 3 is supposed to inhibit thrombin, right, which is factor 2. So it's primarily going to inhibit thrombin. Now, thrombin, if you guys know, it's supposed to activate factors 5, it activates factor 8, it activates factor 9, it also helps to convert fibrinogen into fibrin, so it does a lot of stuff. So having a increased activity of antithrombin 3 leading to a decreased activity of thrombin can definitely prevent clotting significantly. But the other thing that can happen here is that it can also inhibit factor 9 and factor 10. And so you can get these diminished levels of factor 10 and factor 9 and thrombin. But again, remember thrombin helps to activate a lot of different factors, especially factor 8, especially factor 9. And on top of that, it also plays a role in activating factor 5. With that being said, antithrombin 3 can really diminish the activity of all of these. And if you look here, what's the big factor that's really involved in the intrinsic pathway? Factor 9. So you could see some contribution there, again, particularly from the PTT. But again, remember that thrombin is also important in being able to activate factor 5 and activate factor 8. So factor 8 is very crucial in the intrinsic pathway. And so if you inhibit thrombin, technically you inhibit factor 8. And that also affects the intrinsic pathway. So this is all going to lead to, again, what? Well, platelets, if there's an injury here, they'll be able to stick. But in all of these scenarios, what can you not lead to the formation of? You don't lead to 1A, right? And what's 1A? That's fibrin. What's fibrin supposed to do? Help to make the mesh. And if you can't lead to him, can you lead to the fibrin mesh? No. And so then you won't be able to form that secondary hemostasis. So this one's pretty straightforward. If you have a patient who is on heparin, they have a prolonged PTT, think about heparin-induced coagulopathy. An acquired coagulation factor inhibitor, this one's really annoying, but it is something that they can test for. So when a patient comes in, I'd say the ones that you want to look for in the exam, is a patient who comes in bleeding and they're postpartum, right? Or they have an autoimmune disease like SLE, rheumatoid arthritis, they have some type of malignancy, so definitely consider this one, or they're getting treated for hemophilia A. And you know, hemophilia A, what's the factor that they're deficient in? Factor 8. So what would they be treated with? Factor 8 concentrate. If a patient is getting factor 8 concentrate, or they have malignancy, or they have an autoimmune disease, or they're postpartum, and usually postpartum patients can have a little bit of an inflammatory autoimmune activity as well, they may generate autoantibodies. So these are autoantibodies. And guess who these autoantibodies are going to be directed against, my friends? They're going to be directed against this guy. What's this guy? This guy's factor 8. And so factor 8 is really important in being able to do what? Combine with factor 9 to activate factor 10, activate thrombin, activate fibrin. And so if a patient has these autoantibodies and they're directed against factor 8, what am I going to do to the activity of factor 8? I'm going to decrease the activity of factor 8. So this is going to really lead to a reduced activity of factor 8. And if I can't get him active, am I going to be able to lead to the formation of thrombin? Am I going to be able to lead to the formation of fibrin? No. And so because of that, will I be able to form a secondary hemostatic plug? No. Big thing to remember as a high yield point for this one is really look about this one. What happens is you get a PTT, all of these are elevated. But if you introduce normal plasma to all of these patients, every single one of them, with the exceptions of really these two, if you give them normal plasma, you could actually do what in these scenarios? You could normalize their PTT. And the reason why is you're giving them the factors that they're deficient in these particular scenarios. If you give them normal plasma and they have antibodies or they have a drug, all these things are going to keep doing is blocking those plasma proteins. So it's not going to matter. So the PTT never normalizes in these two scenarios. All right, that's a little tidbit, but we'll talk about that in the diagnostic section. Now that we've nailed down the abnormalities of the PTT, what are some abnormalities in the PTINR? All right, so now we're going to talk about the causes of extrinsic defects. So if you have a patient with an increased PTINR, and they may have an increased PTT sometimes, especially in vitamin K deficiencies, but if you have primarily, let's say, just an increased PTINR, you should really be thinking about factor VII deficiency and vitamin K deficiency. And when I say vitamin K, this one causes more of a prolonged PTINR if it's more mild or it's in the early stages of vitamin K deficiency. If it gets to the later stages or more severe vitamin K deficiency, it can then kind of start causing the effect of both pathways to be more significantly impacted. So in these particular scenarios, when I think about these, this one is extremely rare, so I won't spend a lot of time talking about it, but this is usually inherited. So this is usually some type of congenital deficiency. What happens is there's some type of problem where the liver isn't able to adequately produce enough factor VII, right? So there's some type of, let's say, again, a mutation that's occurring that's leading to the liver unable to produce an adequate amount of factor VII. If I don't have an adequate amount of factor VII, what's the problem with this? Well, then I won't be able to combine with tissue factor, lead to the formation of thrombin. If I can't lead to the formation of thrombin, can I lead to the formation of fibrin as well? No. And so what happens is this leads to the downward cascade where I get less fibrin formation. And if there's less fibrin formation, will I be able to form that, fibrin mesh? No. Will I be able to form a primary hemostatic plug? Yes, but this is the part that becomes impaired. So factor VII deficiency is relatively rare. The big differences between really determining if it's a deficiency of only factor VII versus a vitamin K deficiency, if you give a patient vitamin K who has factor VII deficiency, it won't really improve. The reason why is vitamin K works on the vitamin K epoxide reductase enzyme in the liver. If that liver has a hepatocyte who has a mutation in the chromosome that makes factor VII, it won't matter as much vitamin K as you give them. It's not going to make a substantial difference in their factor VII. So that's one way that you could clinically tell the difference is give them a trial of vitamin K. If it improves, it's probably deficiency of vitamin K. If it does not improve, it's probably a factor VII deficiency, and you'd have to check that level. For vitamin K deficiency, this is much more common. So oftentimes when a patient has a prolonged PTINR, you have to kind of go down the line and say, what could it be due to? So there's a couple different things. One is it could be due to a reduced intake. And so depending upon the types of food that the patient is taking in, it could be due to that. I'd say that that's usually in really, really severe starvation. Another potential scenario is when there is a malabsorption, and I would say fat malabsorption. So some type of fat malabsorption. And so there's a lot of different types of disorders that cause fat malabsorption. Just to give you a couple of them, think about it. Could be due to celiac disease, could be due to Crohn's disease, it could be due to tropical sprue, Whipple's, relatively rare, exocrine pancreatic insufficiency, and you know what else another one is? Bile acid insufficiency. So maybe if there's a stone somewhere in the common bile duct, that can also do it. So fat malabsorption is a really, really big one. Another one is bacteria, particularly help to synthesize vitamin K in our gut. If you put a patient on a lot of antibiotics, the antibiotics can break down the vitamin K synthesis in the gut, and that can lead to vitamin K deficiency. So it could be due to antibiotic use, especially if it's prolonged. And the last one, and I'd say the most important one, is a drug that acts to inhibit the liver's synthesis of factors 2, 7, 9, and 10, and that is warfarin. So warfarin can definitely cause a vitamin K deficiency. Now, let's think about this. Again, patient's supposed to get vitamin K via the diet. So here's our vitamin K. So if there's a deficiency in that part, the intake aspect of it, that will lead to a diminished vitamin K. If also there's fat malabsorption. So you know vitamin K is a fat-soluble vitamin, so it's supposed to be incorporated with the fat globules. So here I'm going to represent this. This is our fat. All right, and then inside of this fat, we're going to represent the vitamin K. It's supposed to be a vehicle by which we transport the vitamin K. So if a patient has fat malabsorption, maybe they're not putting the bile into the actual small intestines to help to emulsify the fat. So bile acid deficiency. Maybe they're not making pancreatic lipases from the pancreas. So pancreatic insufficiency, they can't break down those triglycerides. Maybe they can't even absorb those fats because of Crohn's or celiac disease. In those scenarios, then even if this is the case where you have a normal vitamin K, but you have an impairment in this process, then that's going to lead to low vitamin K. The other thing is if you have bacteria. So here, let's represent that I have some bacteria present. Bacteria love to synthesize vitamin K. So they actually help to produce vitamin K, and this can get into the bloodstream. All right. So they help to make vitamin K. If you put a patient on prolonged antibiotics, what are you going to do to the bacteria in your gut? You're going to destroy them. If I destroy the bacteria in my gut, am I going to be able to synthesize vitamin K? No. And so that leads to a deficiency in vitamin K. The problem with that is that vitamin K goes to the liver. It's involved in an enzyme. This enzyme, here we'll represent it in blue, it's present inside the liver, right, in the hepatocytes. This is called vitamin K epoxide reductase. You're like, what the? This K epoxide reductase. This enzyme is involved in being able to really help with the synthesis of particular coagulation factors. And these coagulation factors are as such. Factors 2, factor 7, factor 9, and factor 10. Now, if I have a decreased intake of vitamin K, I don't absorb the vitamin K, my bacteria that are supposed to be producing vitamin K aren't there, or I have a drug that's inhibiting these enzymes, the vitamin K epoxide reductase. So I'm going to inhibit this enzyme. If I inhibit these, will I be able to synthesize factor 2, factor 7, factor 9, and factor 10? No. So here's the interesting thing. Factor 7 has the shortest half-life. So in other words, it doesn't live very long. All right, I'll put T half, so that's the shortest half-life. Meaning that whenever you produce all of these clotting factors, the first one to be deficient quickly is going to be factor 7. So it's going to drop precipitously the quickest. Which pathway is factor 7 involved in? Intrinsic or extrinsic? Extrinsic. So that's why in patients who have early or mild vitamin K deficiency, they may only present with an elevated PT-INR. But as the disease progresses, so here's the caveat. If it becomes severe, so let's say late or severe vitamin K deficiency, what will happen is this will then start to lead to what? A drop in the production of all these other coagulation factors, enough that it can actually start to cause prolongation of the PTT. So eventually, this may cause a prolonged PTT and PT-INR. But usually, the most common one that you're going to see is you're going to see that leading to an elevated PT-INR primarily, plus or minus an elevated PTT depending upon the severity of the vitamin K deficiency. Whew, that was a lot, right? But that's the big thing. So if a patient has intrinsic defect, again, you think about hemophilia A, hemophilia B, severe von Willebrand's disease. I think about heparin use, or I think about an acquired coagulation factor inhibitor. If it's extrinsic, I think about a rare congenital deficiency of factor 7. It wouldn't get better if I give them vitamin K or vitamin K deficiency. I give them vitamin K and they improve. Think about it. Are they not taking in enough? Are they not absorbing fat, which needs to be used as a vehicle to bring vitamin K in? Or am I giving them too many antibiotics and I'm clearing out their gut microbiome? Or is it warfarin use and that's suppressing the activity of vitamin K in the liver? Sometimes you can even add cirrhosis into this area as well, because that can also suppress the liver's production of vitamin K as well. But I want you to remember this one. That's the big one. All right, and then again, take all of this, remembering that these both will prolong the PT-INR, but in the late and severe cases of vitamin K deficiency, it can start to drop these other ones more, that it causes the prolongation of PTT. All right, we hit the last ones here, which are the combination of intrinsic and extrinsic defects. All right, so now into the next part, which is again, what happens if there is a abnormality in both the pathways? And so this is when you want to think about DIC and cirrhosis. So disseminated intravascular coagulation. This one I want you to think about in a couple different scenarios. I'd say the biggest things to be concerned about with this one, and I'm going to do this one a little bit odd here, but we're going to kind of say it like this. You want to think about this in sepsis. That's a really, really big one. I would also be considering this in trauma. I would consider this a malignancy, especially like acute myelocytic leukemia. There's the variant of it, the APL, acute promyelocytic leukemia. And then the other one is obstetric complications, particularly placental abruptions. Those are usually the big ones. Now, what happens here in DIC is that all of these conditions in some way, shape, or form create kind of an inflammatory like cytokine storm. So it's either a combination of really, really bad inflammation that's characterized by a lot of different cytokines that are being released, all right? And so in some way, shape, or form, this is precipitating some type of inflammatory event via cytokines. Placental abruption is a weird one. It actually can just directly, it's amniotic fluid can actually have like tissue factor in it. And so you can increase your tissue factor production. But basically all of this kind of inflammatory process, what it does is they're going to activate all the procoagulants that are part of the intrinsic and extrinsic pathway. So we're going to put all procoagulants. And so essentially that kind of encompasses our intrinsic and our extrinsic pathway. So then that process is really interesting because then what happens is these procoagulants in combination with platelets. So let's represent a couple different platelets that are kind of moving here as well. These platelets, they're also going to be incorporated into this process. And what happens is the combination of platelets and this increased presence or increased activity of procoagulants leads to widespread thrombosis. So now I'm going to cause all these thrombi. All right, you're probably like, Zach, you said coagulopathy, bro. Aren't they going to be bleeding? Yes, but hold on. When this processes trigger massive inflammation systemically, these cytokines activate procoagulants and platelets then lead to the formation of microthrombi. And I'm not talking about a couple, I'm talking about a lot of microthrombi, like widespread, diffuse all over the place. The problem with this is that in order to make the microthrombi, I need platelets. In order to make the microthrombi, I need procoagulants. Factor 12, 11, 9, 8, 5, 10, 7, 3, all of them. I need all those coagulation factors. And so what happens is in the process of consuming these coagulation factors to make clots, I end up with less clotting proteins. So what happens is this causes consumption of all clotting proteins, man. And so then what ends up happening is you end up with a deficiency of every single one of them. That's what's terrifying. And if I have a deficiency of all clotting proteins, what is that going to affect? Factor 7, factor 3, factor 12, factor 11, 9, 8, 7, 10, 2, the whole list goes on. But basically, I'm not going to be able to lead to the formation of fibrin. And because of that, if I have a deficiency in fibrin, am I going to be able to form that secondary hemostatic plug? So if there's an injury in the blood vessel, the platelets will stick, right, to some degree, but will the fibrin be able to form this secondary hemostatic plug? No. And so that's where this problem kind of exists. But there's also another component in DIC is that you actually don't even have enough platelets because you consume the platelets. And so technically to a degree, I could even say that we don't have enough platelets to stop that clot or to form a clot, and that can cause progressive bleeding. So here's the really important thing to remember for DIC. With DIC, you consume all clotting proteins. So when I look at these patients, I'm going to have clotting proteins that are affecting both their PT-INR and their PTT. So what would I expect if I looked at these patients' blabs? I would expect them to have an elevated PT-INR. I would expect them to have an elevated PTT, right? Because why? They're having decrease in all clotting proteins. That includes factor 7 and tissue factor. And it includes factors 12, 11, 9, 8. The other thing that's really important here to remember is that not only are you consuming the clotting proteins of the intrinsic and extrinsic pathway, but you consume proteins of the common pathway leading to fibrin, right? So what's the protein that's needed to really make the fibrin mesh? Fibrinogen. And if you have widespread clots, aren't you gonna have to use a lot of fibrinogen to make those clots? Yeah, so what happens to the fibrinogen? It gets consumed, bruh. And if the fibrinogen gets consumed, what happens to the levels of fibrinogen? That thing gonna drop. The other thing is you're using platelets to make these clots. So not only using clotting proteins, not only using platelets, not only using fibrin, but if you're consuming the platelets, what should happen to the platelets? They should drop, bruh. So I got a drop in my platelets, I got a drop in my fibrinogen. When you make clots, you have a natural homeostatic mechanism that we want to kind of prevent those clots from continuing to propagate. So we try to dissolve some of them. And so we have plasminogen that comes in there and it helps to be able to activate plasmin, and plasmin helps to try to break down some of the fibrin, and you get fibrin degradation products. One of those is D-dimer. So D-dimer is kind of a good sign of a kind of what I'd say about a high clot burden, if you want to think about that. And so D-dimers are going to be elevated because they got clots all over the place. So D-dimer will also be elevated. But here's the last thing. Red cells. They're supposed to be moving through this. How are you going to move through this clogged up highway? It's going to come through here and it's going to get shredded to pieces. And when that thing comes out, it's going to be mangled like the Hamburglar. And so now you're going to end up with these goofy looking red cells. What are these things called? You ripped them in half. They're called schistocytes. The presence of schistocytes really heavily suggests the presence of a hemolytic process, especially DIC. So DIC, in the presence of an inflammatory disease, widespread clots, consuming clotting proteins, consuming fibrinogen, consuming platelets to make those clots, leads to a subsequent, unfortunate, and ironic deficiency in fibrinogen, platelets, and all clotting proteins. Signs of clots can be elevated D-dimers, and ripped up red blood cells can be schistocytes. One other thing. Endothelial cells make factor 8, not the liver. And so in a patient who has DIC, they have a deficiency in all clotting proteins, including factor 8. So this patient would also have a deficiency in what's called factor 8. Why is that important? I'll explain in a second with cirrhosis. Cirrhotic patients, they have fibrosis of the liver, right? So they have some type of fibrosis of the liver. That fibrosis of the liver leads to a couple different things. One is it leads to the inability to produce particular clotting factors. So it leads to the decreased production of all clotting factors except which factor? Factor 8, because that's made by your endothelial cells. So there is all of these factors that are diminished except factor 8. Now, if I'm not able to produce all of these clotting factors that are part of the intrinsic and extrinsic pathway except for factor 8, what's going to happen? What's going to happen to the actual fibrinogen levels? Fibrin levels. I'm going to lead to less fibrin. Less fibrin leads to less clots. So now, with that being said, for a cirrhotic patient, they will have an increased PT-INR because they're affecting all clotting factors except factor 8. They'll have an increased PTT because they can still affect factor 12, 11, 9. What else? Fibrinogen. Well, the liver, again, does make all clotting factors, and that includes fibrinogen. So fibrinogen could be depleted. All right? Not because of a consumptive process, but because of a production process. All right, what else? Platelets. Funny enough, the liver actually makes a molecule called thrombopoietin, which is supposed to stimulate platelet production. And so if you have less TPO, you'll have less platelets. So less TPO, less platelet production by the bone marrow. The other thing is that the liver can lead to portal hypertension. And that portal hypertension can lead to splenomegaly. And that splenomegaly, that big old spleen, can sequester platelets. And if it sequesters the platelets, it can drop the platelets. So can patients with really bad cirrhosis have thrombocytopenia? Absolutely they can. All right. What about a D-dimer? Would that be elevated in cirrhosis? It shouldn't, unless they have another concomitant disease going on. So I would say D-dimer should be relatively normal. And the other thing is there any hemolysis that's going on here? No, I don't see any dang hemolysis that's going on. So there should be a normal D-dimer, and there should be an absence of schistocytes that are present on peripheral blood smear. And last thing, does the liver make factor VIII? No. So what would happen to the factor VIII levels? All the clotting factors would be deficient except for factor VIII. So I would check this and they would have a normal factor VIII level. So that's one of the big differences. So when I think about a cirrhotic patient, I'm thinking about a patient that has more underlying history of cirrhosis, right? And they're going to have particular causative factors there. Alcohol abuse, non-alcoholic fatty liver disease, autoimmune hepatitis, viral hepatitis, increased LFTs, hepatomegaly, splenomegaly, etc. So you'll see some features in the vignette that really suggest that. But the big laboratory differences here is that they're going to have somewhat of a similar coagulopathic panel, right, via these. But the D-dimer, the schistocytes, and the normal presence of factor VIII really kind of helps in that. Because sometimes it can be difficult to discern, is this a really bad cirrhotic patient who's decompensated in acute liver failure or a DIC patient? All right? Now, with that being said, we've now talked about a patient who is a prolonged PTT and a PTINR. And we try to more kind of differentiate these two by a couple other factors from their pathophysiology. What I need you to remember is when a patient comes in with a coagulopathic bleed, what does that look like? It's a good reminder here. You want to look for ecchymosis. All right? So these big kind of hematomas that appear of the skin, which look like this. It can also cause a lot of swelling and blood to accumulate in the synovial joints, which can lead to hemarthrosis, which can look like this. And then on top of that, sometimes patients can have a lot of prolonged bleeding from surgical incision sites. So really, you want to watch out for any kind of evidence of prolonged bleeding, especially after surgical procedures. All right, so especially surgical bleeding. The other thing is in rare cases, but severe cases of coagulopathy, especially DIC, cirrhosis, and vitamin K deficiencies, you really want to watch out for the evidence of upper GI bleeds, which can be presenting with what? It can present with melena and hematemesis, or you can want to watch out for hematochezia, all right, which can be presenting via lower GI bleed. And then lastly, you want to watch out for any kind of evidence of intracranial hemorrhage, which can present with obviously changes in their mental status, neurological focal deficits, depending upon where it exactly occurs, and headaches. So these are really important things to be thinking about when you have a patient coming in with evidence of bleeding. Really think about these ones right here to think about a coagulopathic bleed as compared to a platelet disorder related bleeding. And these are the worst case scenarios that you really want to try to avoid. All right, my friends, now that we've done this, let's now tee ourselves up to talk about the diagnostic approach. I have a patient comes in and with bleeding, and I have to determine is it superficial. The reason why superficial bleeding suggests platelet disorders. If I see petechiae, purpura, gingival bleeding, menorrhagia, or potentially epistaxis. But if I see deep bleeding, I see brain bleeds, GI bleeds, hemarthrosis, ecchymosis, or bleeding from surgical sites or catheters or IVs, that's coagulopathic bleeding. That's something I want to think about right off the get-go. Either way, for both of them and with bleeding, you always check the CBC and get your coagulation parameters. When I do that right away from the CBC, I'll be able to tell, does the patient have thrombocytopenia? Oh, they do? That could be the reason that they're bleeding. Also, if their platelets are normal, but they have a prolonged bleeding time, not the PT-PTT, their bleeding time, that could potentially suggest a platelet dysfunction, right? Now, if a patient has some type of abnormality in their PT or PTT despite their platelets, they could still have a platelet disorder and coagulopathy. That's not out of the world to see. What you want to know is, okay, do they have normalish platelets, but their PT and or their PTT is elevated? Then I'm concerned about a coagulopathy. Again, check the CBC. Platelets low, thrombocytopenia could be their cause. If the platelets are normal, but their PTT is completely stone cold normal, and their bleeding time is prolonged, it could be platelet dysfunction. Regardless of what their platelets is, believe it or not, usually in this scenario, for perfect scenario, we'll say platelets are normal. All you care about is what's their PT and their PTT. If that is elevated, we have a coagulopathy at play, and we got to figure out which kind it is. So say that we start off with an increased PTT and a normal PTINR. What is this? Intrinsic defect. So then we got our differential. It was hemophilia A, hemophilia B. It was a severe von Willebrand's, acquired coagulation factor inhibitors, and heparin. What I want to do is a mixing study. All right. So basically what happens is you take the patient's blood. All right. And let's say that in this scenario, you have some clotting factors and they have autoantibodies. Ooh, autoantibodies. That was really helpful in the acquired coagulation factor inhibitors. Okay. And sometimes it can even be helpful in heparin, because heparin actually can act as it's an acquired coagulation factor inhibitor. Either way, you take this patient's blood who either has heparin in it or an autoantibody, and you introduce it to normal serum plasma, normal blood, which can have a bunch of different types of proteins in it, clotting factors. If you mix these two that has clotting factors and the patient's blood that has the autoantibody in it or the heparin in it, what do you think will happen? If you mix the two, all that's going to happen is the autoantibodies or the heparin will bind to all these coagulation factors and basically prevent it from working. So will the PTT actually correct when you mix it with that patient's blood? No. It will not correct. This is suggestive of an acquired coagulation factor inhibitor when the PTT remains prolonged. This is either that factor VIII inhibitor like in SLE, RA, malignancy, postpartum, or treatment with hemophilia A precipitates, particularly the factor VIII precipitates. If I take the patient's blood and they don't have any coagulation proteins, they have a factor deficiency, and you give them normal blood, which actually has all of these clotting proteins present, what will happen? So their PTT was prolonged because they had a deficiency here. All right. This PTT was prolonged because they have autoantibodies binding to the coagulation factor, factor VIII in this case. In this one, I have no autoantibodies. I just don't have enough of these proteins, and I give them normal amounts of these coagulation proteins. What will happen to their PTT? Will it improve? Absolutely it will, because now I have coagulation proteins that I can introduce to start helping them to clot. That will cause the PTT to actually start to decrease or normalize. That suggests a factor deficiency. So what I want you to remember is when you have a patient who bleeds and their PTT is prolonged, you do a mixing study and it stays prolonged, it's an acquired coagulation factor inhibitor. If it does improve, it normalizes or decreases, it's a factor deficiency. That's super, super important. So let's say that we take the patient who it does not normalize and it's a coagulation factor inhibitor. What I want to do is I want to know, are they using heparin? That's the easiest way to go about this. Are they using heparin? If they are, all right, it's probably heparin coagulopathy, done. If they are not using heparin, you got to think about that weird acquired one. And if that's the case, you got to start thinking, okay, could this be the, acquired coagulation factor inhibitor from SLE, from RA, from postpartum, from them getting treated for hemophilia A? Those are things to consider. Now, with this being said, sometimes what we actually they love to throw this on the exam, especially with these kind of scenarios. Antiphospholipid syndrome is not per se a coagulopathy. It's actually more of a hypercoagulable state. But what happens is very paradoxical. When you have a patient who has a prolonged PTT and they actually have no normalization of their PTT and they're not on heparin, and you can't really find an acquired coagulation factor inhibitor that's actually occurring here, you always want to think about antiphospholipid syndrome. And what we do is we actually do what's called the, after this part, we do what's called the dilute Russell Viper venom test. And if the patient's PTT does not correct with the Russell Viper venom test, it's because they have a lupus anticoagulant that's preventing this. And so that's really, really important. So if you ever have a patient who comes in and you check their PTT and it's prolonged, you do a mixing study and it doesn't normalize, and they don't really have heparin use, and you can't find an acquired coagulation factor inhibitor cause, check the dilute Russell Viper venom test. If it doesn't actually prolong, it could be due to the lupus anticoagulant, which we see in antiphospholipid syndrome. That's something to consider about. All right, if the PTT normalizes, that's a factor deficiency. We just have to figure out if it's due to factor 8 deficiency, factor 9 deficiency, or is it severe von Willebrand disease? So what I want to do is I actually want to check factor 8. I want to check factor 9, and I want to check von Willebrand factor activity. And then on top of that, I want to check that risdosine cofactor assay, which we talked about in the platelet disorders, because it's going to tell me if I do that study, and they don't aggregate, and I add plasma-rich von Willebrand factor to the scenario, and they do aggregate, that's diagnostic of von Willebrand disease. So let's say I do this, and I see low factor 8 activity. That is hemophilia A. If I check it and there's low factor 9 activity, that's hemophilia B. And if I check it and the von Willebrand factor activity or antigen activity is very low, and on top of that, the risdosine cofactor assay tells me that there's no aggregation, but when I add the von Willebrand factor to the mix, it does aggregate. That tells me it's severe von Willebrand disease. All right. Now, from here, I've taken care of the intrinsic pathway. What if I have just a pure extrinsic pathway defect, meaning the PTINR is elevated, but the PTT is normal? Again, could be congenital deficiency, right? That's very rare, but it is something to think about. But most of the time, it's a vitamin K deficiency, early or mild vitamin K deficiency. How would I actually prove this? Give them vitamin K. You can't hurt them to a degree. Give them vitamin K. If you give them vitamin K, what will happen is if it does not improve the PTINR, it's a congenital deficiency. Because in a congenital deficiency, the liver can't produce factor 7. It doesn't matter if you give them vitamin K or not. It's not going to produce more factor 7. So PTINR isn't going to improve. That's congenital, right? That's a factor 7 deficiency. But if you have a patient who is not taking enough vitamin K in, they're on antibiotics that's suppressing vitamin K production by the bacteria in their gut, they have a fat malabsorption, you give them IV vitamin K. We bypass all of these different ways and we get it straight into the bloodstream, we get it to the liver, and the liver starts producing factors 2, 7, that's the important one, 9 and 10. What's going to happen to their PTINR? It will improve and it'll start to normalize and go down. If that happens, it's a vitamin K deficiency. Boom, roasted, we did extrinsic. If I have a patient who has a increased, all right, boom, roasted. Now here, let's take a second to remember. Again, with factor 7 deficiency, again, you're looking for a family history, a personal history of bleeding. But with vitamin K deficiency, you're looking for that warfarin toxicity. So look for a patient who's taking warfarin. That's a really important one. Look for newborns who didn't get an IV vitamin K injection upon their birth. Look for fat malabsorption disorder, so a patient with weight loss and steatorrhea, those foul-smelling fatty stools. And look for prolonged antibiotic use that could be suppressing their intestinal flora production. All right. Now, that covers the extrinsic pathway defects. If a patient comes in and they have a prolonged PTT and a prolonged PTINR, you have to come to the decision of, okay, could this be severe or late vitamin K deficiency, DIC, or cirrhosis? And this is probably a combination of both pathways being defected. Guess what I should do right away? I should actually do a vitamin K trial again. Because believe it or not, anytime the PTINR is elevated, you should always just kind of try a vitamin K trial. If the vitamin K upon administration improves the PTINR, it's probably a vitamin K deficiency. It's probably a very severe one if they have both an increased PTT and a PTINR. But if it does not improve it, it could be DIC or cirrhosis. So how do we really go about this? Remember I told you, DIC cirrhosis, we look at the PT, PTT, we look at the platelets, we look at the D-dimer, we look at the fibrinogen, and we look for schistocytes, and lastly, factor 8 levels. So let's do our DIC panel. Let's check a peripheral blood smear, and let's check factor 8 levels. The DIC panel will give us the fibrinogen and the D-dimer, which is going to be pretty helpful as well. So if I check that and I see no schistocytes, right away there's no hemolytic anemia, that supports cirrhosis. If I got a low fibrinogen but a normal D-dimer, again, there's no heavy clot burden, but the liver isn't maybe producing enough fibrinogen. And if I have normal factor 8, factor 8 normal, that's cirrhosis, baby. But if I look and I see schistocytes present, that means that there's thrombi ripping the red cells up. If there's low fibrinogen and an increased D-dimer, that means I'm consuming clotting proteins that consumes fibrinogen, and my D-dimer is up because I have a heavy clot burden, microthrombi all over the place, and there's low factor 8 levels, that's DIC, my friend. So that's something to definitely be concerned about for DIC. Now, DIC also really involves history. Is a patient septic? Have they had a significant trauma? Do they have a malignancy like acute myeloid leukemia? Have they recently had a placental abruption? And then also, in their history, if you ever read oozing from IV sites, always be suspicious of DIC. For cirrhosis, you're looking for a patient who has underlying stigmata of liver disease. Do they have ascites? Do they have palmar erythema? Do they have spider angioma? Do they have potentially hypoestrogenism, so decreased libido, testicular atrophy? Do they have gynecomastia? Do they have some type of jaundice? So look for those things. And do they have a history that would suggest that disease? Alcohol abuse, non-alcoholic fatty liver disease, hepatitis. Those would really lean more towards the cirrhotic picture. All right, this really gives us a strong idea of how to really work up and think about coagulopathy in a true clinical manner. How do we treat it though? That's really important, right? If a patient's bleeding, I need to know how to treat it. So first off, you need to treat the underlying disease. If a patient has von Willebrand disease, it's actually kind of straightforward. For minor bleeding, or they're just kind of getting a minor procedure. What I mean by a minor procedure, that could really just be like you're doing a central line, or you're doing some suturing, like you're doing very, very minor things. You're inserting a Foley catheter, something that puts them at very mild risk of bleeding. You could give them DDAVP prior to that. The concept behind DDAVP is that what it's going to do is it's actually going to stimulate the endothelial cells to produce von Willebrand factor, and that's going to basically help with the platelets sticking here and cause that clotting to occur. But in severe cases where a patient's really bleeding, they got brain bleeds, GI bleeds, they have excessive kind of bleeding, or they're getting ready to actually get a full-on surgery. Maybe they're getting an XLAP. Maybe they're getting some type of cardiac surgery. You really should prevent them from having significant catastrophic bleeding. And so you'll give them von Willebrand factor concentrate. And that's literally going to increase their von Willebrand factor and help with that sticking of the platelets to the actual broken up blood vessel lining. All right? So mild DDAVP, severe von Willebrand factor. Now, hemophilia is a little bit different. We actually can, again, in hemophilia A, we can give them DDAVP. It's actually really interesting because think about it. DDAVP does what? Increases the production of von Willebrand factor. What does von Willebrand factor do? It prevents factor VIII degradation. So it keeps factor VIII levels normal, at least kind of normal-ish, and so you can prevent them from continuing to have bleeding. So it's a good prophylaxis for very minor procedures, or they have very minor bleeding. If they're bleeding pretty bad, then you give them factor VIII concentrate. Now, hemophilia B, you give them factor IX concentrate, all right, because your problem is a factor IX deficiency. The last thing that we could consider is if a patient has hemophilia A, they have minor bleeding, you give them DDAVP. All of a sudden they have severe bleeding, you give them factor VIII concentrate. If they still continue to have recurrent bleeding, despite DDAVP and factor VIII concentrate, and then you check their actual factor VIII activity level, and that's less than 1%, dude, you have to give them something that can actually act as a glue. It can literally kind of act like factor VIII basically, and it can help to glue factor IX and factor X together and activate factor X. And that's where this drug called imikizumab comes into play. It's basically kind of act like a artificial factor VIII to a degree, except it's not factor VIII. It kind of acts like it, and it's a glue, and it takes factor IX and binds with it and then activates factor X. So it kind of acts like factor VIII, which is kind of interesting. But you only do this if they continue to bleed despite this, and their activity is so low that we just basically don't even give them factor VIII at this point. We just prophylactically give them imikizumab. All right, heparin coagulopathy. The only reason we would actually reverse heparin is if a patient is bleeding or they're about to get a super invasive procedure like a cardiac surgery, any kind of surgery that poses a risk of bleeding and they wouldn't be able to stop bleeding. We give them protamine sulfate. The concept here is heparin, again, increases antithrombin 3, which decreases the activity of factor X, IX, and thrombin. So what I want to do is give them protamine sulfate to inhibit that activity of heparin. That decreases antithrombin 3 and then basically increase the activity of these so that they can actually initiate clotting. So that's what we would do if a patient is having an heparin coagulopathy. We would actually watch their PTT to make sure that it's improving. Vitamin K deficiency is super high yield. I really need you to pay attention right now. If a patient comes in, they have an increased PT-INR on its own, or an increased PT-INR and PTT, and you have bleeding. And specifically, the most common one that you're going to be tested on is warfarin use. When they bleed due to a vitamin K deficiency, you can't just give them vitamin K only. What you're going to do is if a patient comes in, let's say the clinical vignette says you have a patient coming in, they're on warfarin and they're bleeding, they have a brain bleed. You give them what's called Kcentra or 4-factor PCC. 4-factor PCC replaces, it's basically essentially factors 2, 7, 9, and 10. You're giving them that. You're replacing and that's going to act quickly and replace those clotting factors so that you can actually stop the bleeding right away. But then you're also going to give them 10 milligrams of IV vitamin K, because while this stuff is cooking and it's working, you need the IV vitamin K in the background to tell the liver to start producing more factors 2, 7, 9, and 10. So what you're going to do is you always give both of these right away in an active bleed. If the patient is not bleeding, they are not bleeding, you do not need to give them PCC and you don't need to give them IV vitamin K. What you want to know is what's their INR? Is it super therapeutic? So let's say that you have a patient who has a very elevated INR, but they're not bleeding. They're asymptomatic. They just have a super therapeutic INR. It's due to warfarin oftentimes. If the INR is greater than 10, we give them 5 milligrams of oral vitamin K. And if the INR is greater than 5 and they're asymptomatic, we can give them 2.5 milligrams of oral vitamin K. All right. So bleeding while on warfarin, doesn't matter what the INR is, PCC, IV, 10 milligrams vitamin K. Not bleeding, then you determine where is the INR. Is it greater than 10? 5. Is it, in this case, greater than 5 but less than 10? You give 2.5 milligrams of PO vitamin K. No PCC for either of those. DIC or cirrhosis, these patients can really bleed, man. And so we oftentimes just do a lot of supportive care for these. You can give them platelet transfusions because both of them are going to be low in platelets, but we only really do that if they're less than 10,000 and asymptomatic. We just want to reduce the risk of spontaneous hemorrhage. Or if they're bleeding or they're getting ready to get an invasive procedure and their platelets are less than 50K. All right, that's one potential reason. For the platelets, again, the whole point here is that you're trying to give them to increase the platelets, but you only do it upon these particular scenarios. FFP is all of your coagulation protein. So if a patient has both an increased PT or an increased PTT and they're bleeding or they're about ready to get a procedure where they are at risk of bleeding, you should give them FFP. You're replacing all of their coagulation proteins plus fibrinogen plus von Willebrand factor so that they'll be able to clot if they need to. And lastly, cryoprecipitate can be given if they have active bleeding despite FFP and their fibrinogen's less than 100. So in these potential patients, both of them, they can have hypofibrinogenemia. And so if I need to give them cryoprecipitate, I will give them that because it's very, very high in fibrinogen. I'm replacing the fibrinogen deficiency. All right. So again, these ones, really the only way that we're treating the coagulopathy is giving them platelets because they're going to be both low in platelets, giving them FFP because they're both going to be low in all coagulation proteins. The only exception is cirrhosis is not deficient in factor VIII. And then cryoprecipitate, they're both deficient in fibrinogen. So we have to give that fibrinogen back. My friends, this covers coagulopathy. I really hope that you guys liked it. I hope that you learned a lot and I hope it made sense. I love you guys. I thank you guys. And as always, until next time.